Hi, my name is Kim Nyenhuis, and I'll be presenting on Chapter 1 from Susan Melka, Hospital Hierarchies and the Duty to Care. Nursing is warfare, and the nurses are soldiers. Nurses felt World War II was one of the most influential factors in their nursing careers. About one-third, or 76,000 nurses, served in the armed forces during World War II. They were thought of as heroines and angels, and the war enhanced the nursing prestige, calling them brave, with a great sense of duty to the soldiers. The military needed nurses desperately, but excluded male nurses because nursing was still considered a woman's role. One soldier stated, "Nurses are like your mother and sister rolled into one." Nurses experienced autonomy during the war, which ended when they returned, making it difficult to return to hospitals. American society was conflicted with the role of women in the workforce after the war. The women who took over for men in the factories went back to being housewives, yet the hospitals were still desperate for more nurses. This set up for an ideological contradiction. Should a woman be a housewife, or should they earn money as a nurse? In 1947, about 6,000 nurse veterans used their GI Bill to attend college. This group became the nurse educators, who began teaching nurses instead of the physicians. From home to hospital. Between 1946 and 1952, admissions to hospitals increased by 25% because of government funding and private insurance. After the war, the majority of the nurses worked in the hospitals instead of private home care. Private nurses moving into a hospital setting found a loss of independence, autonomy, and authority. As the private nurses moved into the hospitals, the older, less skilled nurses moved into the home-based setting of nursing. Hospital nurses found themselves under more supervision than they were used to in the war. Physicians became the leaders of the hospitals, making it more of a medical and complex institution, and they dominated hospitals for most of the 20th century. By the 1950s, the hospitals began to be redesigned and had an increase in graduate nurses and auxiliary nursing personnel. Under the Hill-Burton Act, federal grants helped hospital construction flourish. Due to the rise of private insurance, private and semi-private rooms replaced the large wards so they couldn't compete for new patients. New areas were also created for medical specialties like ICU, coronary care, and nurseries because doctors started to specialize. Along with the doctors, this meant the nurses specialized, which made a big gap between floor and specialty nurses. Hospital hierarchies. In the 1950s and 1960s, doctors still dominated the nurses. They would still have on the floors what they call the hospital salute, which was a tradition where nurses had to stand in the presence of the physician. They carried the charts for them. They even got up and offered them chairs. The doctors also expected nurses to remind them to renew orders, and even if a sterile field had been compromised. Yet nurses blindly followed doctors' orders without questioning them. I think they did a survey of like 22 nurses, and 21 out of the 22 nurses said that they would still carry out a doctor's order if they felt that it was wrong without questioning them. Within nursing, there were different levels of nursing. There were floor nurses, head nurses, and specialty nurses. Some nurses with many years of experience or working in a specialty developed a certain expertise, as they called it, and began to influence and teach some doctors, especially new interns and residents, what they had learned. Nursing hierarchies consisted of a director, associate director, supervisors, and eventually came to the floors where they had a head nurse, RNs, LPNs, and nurses' aides. RNs began to pull rank over the LPNs, who had less responsibilities than an RN, and LPNs could not wear the same uniform as the RNs. The RNs did not want them wearing or looking the same. In 1950s, More of the hands-on nursing became an LPN or aide duty, with more nurses moving into administration, yet an LPN was not allowed to put information on a patient's chart. The split went along with the racial tension at the time, as in most southern hospitals the aides were black and the nurses were white. As medicine grew, nurses fell farther behind doctors because of their lack of their own science. As the doctors became more advanced, nurses stayed the same. The work of the nurse, caring and duties. The views of nursing started to change. How nurses saw their work was different than others saw it. Although there was still a big gap between doctors and nurses, nurses were no longer doing motherly duties. They were more task-oriented. The definition of care moved to doing what was medically necessary for the patient, no matter if it made them comfortable or not. Students no longer viewed tender, loving care as the most important aspect of nursing. Nurses struggled because they accepted the duty to care for the patient, but there was not much education devoted to this. The nurse as a motherly figure was becoming a part of history. As time went on, nurses were asked to perform more tasks, such as blood pressures, suctioning, and dressing changes, which was more than doctors had done in years past. As the list of tasks grew for more nurses, more ancillary staff was added to help. The nurses performed the doctor's orders, while the LPNs and aides performed the care to the patients. In school, students learned the exact sequence of duties of a staff nurse. This included receiving report, evaluating patients, making rounds, help with breakfast, supervise aides with cares, give medications, make rounds, help with lunch, and visit with patients and visitors, and make notes and chart. It was very routine. Most nurses trained at diploma schools, which taught them to be very task and routine oriented. They were sometimes so caught up in their routine they weren't connected to the patient's problems. They just did the routine without any rationale thinking. Some hospitals expected them to do all sorts of things, like from setting up respirators to mowing the lawn. Above the staff nurse was a head nurse. Over time, the head nurse moved farther and farther away from patient care because hospitals were becoming more complex and technical, which made it hard for the head nurse to provide care and management duties. The meaning of the word nurse was diminishing with the addition of LPNs and aides. The RNs still made judgments on the needs of the patients, but delegated the cares to the LPNs and aides. By the 1960s, the average length of stay for patients in hospitals had dropped dramatically. The care was becoming more specialized, which caused nurses to struggle. Most nurses had not gone farther than the diploma program and no specialized training. It says that there was a study at the University of Michigan Hospital in 1946. The average stay was nearly 18 days, and by 1963, the average stay in the same hospital declined to less than 12 days. And then in Mount Sinai Hospital in New York, in 1951, the average stay was 25.5 days, and by 1965, it dropped to between 11 and 12 days, which is still a lot from days in today's society. 71% of nursing supervisors had no college education in 1954 in the state of Michigan. A diploma from the hospital nursing school was as far as they had gotten. Everything they learned was on-the-job training. By 1962, the average nurse was earning less than a factory worker and teacher. They had no benefits and no say in their working conditions. The nursing workforce was changing from single women to older married women who were getting back to work part-time. 97% of new nurses were white and 99% were female. Nursing was still a gender-segregated profession. Little girls were asked if they wanted to be nurses, and little boys were asked if they wanted to be doctors. As more young women answered yes to nursing, there was a rise in training schools.